So good morning. So today I'll be talking about the ultrasound of lungs. So I think it's very essential not only for the physicians or the critical care doctors, but also we should know everybody. I mean, not only the thoracic surgeons. I think the gynecological people also. It's good to know about this thing. So my outline for today's presentation will be why POCUS. It means point on care ultrasound. POCUS. POCUS. It means the abbreviation for the point on care ultrasound. How and when. Some illustrative examples and the quiz and the future perspective. So actually this POCUS stands for the bedside point of care ultrasound. It's extremely useful in ER, so therefore the another entity that we call is the BLUE protocol. BLUE means bedside ultrasound in emergency. It has been written here, that means the bedside ultrasound in the emergency. So it's very important for the pulmonary physician, in ICU and critical care doctors, and also for anesthesiologists, the internal medicines, and the radiologists. So it's good to know about this entity, this thing. Lastly, I would mention that for every general surgeon, surgical oncologist, thoracic surgeons, or gynecologist, urologist, everybody is good to know about this thing. So why it's important? Because it's the real-time image. Only the limitations are that it's operator dependent, because if I don't know something, that then my eyes will never see the things that's happening in the ultrasound. So if we know something, then definitely you will going to find out those things in the ultrasound monitor. So it's the operator dependent. If somebody is good enough and he knows about all the details of the sonological findings of some entity, then definitely he will find it out in the ultrasound. There is the lack of a structured educational program across the institution. If you talk about DEPAL also, we don't have such a structured program for any physician. I don't know what's happening with the critical care doctors, but we don't have in the thoracic surgery. So it's very good time that we should highlight this important for the thoracic surgeons as well. In a context of surgical emphysema, it's not good, because if there is the air in the subcutaneous tissue, ultrasound is never a good thing, good imaging. It will not have a good imaging quality. So there are several indications. The first is the pneumothorax. So far we are concerned about pneumothorax, that only chest X-ray or CT scan is the best thing, best imaging modality, and we should do the chest X-ray or the CT scan of the chest. But it has been found the ultrasonography is not inferior to chest X-ray, or even better than chest X-ray, and even not inferior to the CT scan. For the pleural effusion, pulmonary edema, pneumonia, lung masses, pleural mass, diaphragmatic dysfunction, placement of needles or catheters, like we do the intrathoracic catheter insertion or chest tube drainage, etc. So it has been mentioned in one of the literature, the sensitivity and specificity. If we compare the lung ultrasound versus chest radiography, we can see the sensitivity and specificity. In some context, like for the pleural effusion pneumothorax, it's even better than the chest radiography. So it has been shown by the literature also, the similar things. So now USC looks not at the lung, but at the artifacts created by the lung. If we talk about the ultrasound of the gallbladder, we look at the gallbladder. We visualize the gallbladder. We can visualize the stones in the gallbladder. If you are doing the pelvic ultrasound, you will visualize the uterus. But if we are talking about the ultrasound of the lungs, you will never visualize the lung properly. Rather, you will see only the artifacts that you are going to interpret that this entity is going on, this condition is happening in the patient. So there are certain probes that we utilize for the ultrasound of the lung. So very popular is this one, the phase array probe. So that may not be available. So we think that for superficial structure we use the linear probe, but for the deeper structure we prefer the curved linear probe. So if we have to say one probe, then I would prefer the curved linear probe, because this will be fit for all the entities, I mean all the conditions in general. So the high frequency probe is the linear probe, the low frequency probe is the curved linear or the phased array probe. So there are several modes also in the ultrasound. So for us, for the basics to start with, we must remember the B mode and M mode. Definitely if you have got the Doppler ultrasound mode, then that will add to your armamentarium. So the B mode has been shown in the upper figure. This is the B mode. Something will be looking like this in the ultrasound of the patient. And the M mode is the motion mode that we'll see like this. So we should be familiar with the B mode, that is the button there in the ultrasound. You can change the modes in the ultrasound machine. In a typical patient, if we do the B mode, we will have in a normal person will have such a finding of such an image in the monitor. So we'll see this is the skin, this is the subcutaneous layer, this is the muscle or fat, muscle layers, and we'll see the two ribs. Here's the two ribs and the shadow reflected by the ribs, and we'll see the pleura and thereafter certain lines. So these lines are called the A lines, so that will visualize very clearly in each and every person, normal person. We'll talk later on about the patient also. If we correlate with the YUM mode, this is the B mode, this one. This below is the YUM modes. The clear pattern we can see in a normal person, like seashore sand. It means the sea will be seen at the top of the screen and the bottom will be sand-like pattern, so that's why it's called the seashore sign. So it's in a normal person you will visualize the similar thing in the ultrasound. So there are several advantages and pitfalls. To name it, that advantage is widely available, it's relatively cheap, we don't need to transfer the patients, especially those who are intubated or critically ill patient. We don't need to transfer to the X-ray department. Portable X-ray can be done, but it's not, and it's also without any radiation, the ultrasound. But only the pitfalls that I mentioned is the operator dependent. If the surgical emphysema is there, it may not be good to use the ultrasonography. So there are several techniques. The preferred position first we have to talk about. So generally if the person can stand or sit, then the upright sitting position is the best one to evaluate for the pleural effusion. Sir, slightly leaning forwards can be used, and also in certain conditions we can use the supine position. If the patient is intubated, definitely you cannot turn the patient, you can use the supine position. The preferred orientation could be the vertical orientation or the transverse orientations of the probe, I mean. So both probe orientations can be used. So these are certain landmarks. So as per the blue protocol, they said that at least 6 stones have to be monitored in one side of the chest cavity. So several lines have been drawn here, and this is how we put the two hands. For example, we are creating the right side of the chest cavity. So we put the two hands. The upper point is called the upper blue point, the lower point is called the lower blue point, and so we draw the lines like this: the parasternal line, there will be the anterior axillary line, there will be the posterior axillary line, and behind will be the paravertebral line. So these lines, then we'll have this vertical line will separate. This is the upper 1, 2, 3, 4, 5, 6. So these 6 zones have to be evaluated properly in order to come to a probable diagnosis or the particular diagnosis in the patient. So these are the similar things that has been shown, radiological image and the regions that we have to analyze. So now let's talk about the key steps of the ultrasound of the lung. So first we start with the visualization of the superficial structures. For that thing, the linear probe is the best one, because superficial structures like skin, soft tissue, muscles, etc. can be better visualized by the linear probe. Indeed, if you are attempting for tapping of thoracosynthesis, then it's good to visualize the intercostal vessels also. So we can see if you apply the Doppler, you can see the intercostal vessels also, so you can avoid the puncture of the intercostal vessels if you are entering inside the chest cavity. We also should remember that pleura is generally 0.2 mm thick, and the gliding of parietal pleura, of the visceral pleura, gives rise to the sliding sign. So this is very important. This is always present in a normal person. So you must look for this sign that is called the sliding sign. In a while, we'll see how it looks like. So these are some of the pictures I showed about the YUM mode. So basically, we should start with the 10 signs of the POCUS or point on care ultrasound. So I will talk about these 10 signs. You can see here. I will play a small video.
Think of it as layers from the outside in, as we've previously discussed. So we have the skin layer, the subcutaneous layer, we have the muscular layer here, then we have the cortex of the rib with shadowing, and the cortex of the rib here with shadowing and shadowing. We have the intercostal area between the ribs, and then and only then can I identify this hyperechoic line below the ribs in intercostal area as the pleural line. Now Lichtenstein sees this as a bat, where the curved ribs are like the wings of the bat. It's like the bat's flying towards you, and then below those wings you can call the pleural lines because it's relatively static. where everything below the pleural line is relatively dynamic. You see all of this sparkling and movement and this artifact that is created. That is the appearance of normal lung sliding. And this is said to look like a seashore or a sandy. What A lines are is horizontal lines that are reverberation artifact of the original pleural line. So we see the original pleural line here, and then we'll notice that equidistant from the skin to the original pleural line, we have a second horizontal line. And then equidistant, again, anatomy that we're used to, with the rib and shadow. And then below the ribs, we see the parietal pleura. And then between the parietal and the visceral pleura, we see that there's fluid. And this fluid takes this quadrangle type of shape because we have the rib and shadow serving as the side borders, and then the parietal and the visceral pleura serving as the top and bottom border. And if we were to take an M mode right down through the middle of this pleural effusion and watch it out over time, what we would see is the parietal pleura here, and then with inspiration and expiration we'd see the visceral pleura moving in and out, which gives us sinus is depicted here, as well as the tissue-like sign, which is depicted here. In both of these are signs of consolidation. Now if we look at this video down here, we see that here we have the diaphragm, below the diaphragm is liver, and above the diaphragm we see a little bit of pleural fluid, but we see this tissue-like area, which is an area of consolidated lung. It almost looks like liver tissue, and that's why some call it hepatization of the lung. Pockets by definition are greater than or equal to 3 B lines per interspace. Some call it the barcode sign. And this is the M mode equivalent of lack of lung sliding. So if we look at this 2D video clip here, we see rib shadowing, rib, a little bit of shadowing. So we know below that is this hyperechoic line that we've identified as the pleural line. But notice, looking at this pleural line, that there's no movement along it. There's movement of the chest wall, but there's not movement of the pleural line back and forth in opposition to each other. So if we contrast that to the seashore sign we've seen before, we can identify that everything above the pleural line is still relatively static. And again, we see the movement in the intercostal and muscular layers from time to time. That's movement of respiration. But below it, we don't see that sandy beach. In fact, Einstein refers to as the stratosphere sign, is the transition between a pneumothorax, or air in the pleural space, and normal lung sliding. And if we look on this video on the left, we see rib, shadow, rib, shadow. And so we know this is the pleural line. But we see movement along the pleural line on this part, and so that is lung sliding. And on the other side, we see no lung sliding. So this transition point between the two is the lung point. And if we were to place M mode on this, we would see that above the pleural line, we have the static area, so no significant movement. Below the pleural line on this side, we see the sandy beach sign with lung sliding, and then that lung sliding goes away here, where we have the stratosphere sign, all in the lung point. Think of it as layer.
So this was regarding a short clip how we perform. So we must remember the 10 signs that we have to recognize during the while performing the ultrasound of the lung. So now what to look for if we begin with chest ultrasound. So first, as I mentioned in the video, there's the A lines we have to look for. We have to look for the B lines and definitely the lung slides. These are normal structures that we will visualize during the ultrasound. So A lines are present normally. If we visualize the normal lung, A lines we always visualize there. About the B lines, it has been said that it's up to 2 in number. B lines means the vertical like this lining. A line means the horizontal line, right? Equidistance. So these are the A lines. These are the B lines. So this vertical distancing like this B lines should not be more than 2 in one vision. I mean, if you orient the probe longitudinally, in one time you shouldn't visualize more than 2. If it is absent, that is also some condition, pathological condition. If more than 2, it's also some pathological condition. So if there are abnormal lines more than 3, it may happen in the pulmonary edema, pneumonia, atelectasis, neoplasm, pulmonary contusion, pulmonary fibrosis, etc. And anything which causes the fluid accumulation in the interstitium, or anything which is causing some illness in the interstitium, that will cause the more and more B line. So this is also very important to remember. So there was a conference and expert panel regarding the point of care lung ultrasound. So it was too long ago. It was in 2012. The first consensus was started. It was published, and thereafter we have been following this since 2012. Recently, in 2022, there was a similar expert panel consensus which has yet to be published. They have done several modifications, but it has yet to be published. I have not seen the article in detail regarding what changes they have made. So till now, as of now, we have been following this 2012 guidelines regarding the point of care lung ultrasounds. So as we remember, everything in medicine starts with A, B, C, D, E. So the lung ultrasound is also not an exception of that. So we start A, B, C, D, E. A stands for the A lines, B stands for the B lines, C for the consolidation. For D, nothing has been nominated. H for E means effusions. So we should also remember just numerics. So any patient, we have to look for these 4 things. So what's the definition of B lines? I said this: the discrete laser-like projections arise from the pleural and go exactly to the pleural. If it's here starting, it will go to the bottom of the screen that you will see. So this is the particular B line that we can visualize during the ultrasound of the lung. So what is a positive region? So it is the presence of 3 or more B lines, that we call it the abnormal B lines. It means the patient is suffering from some illness. So that's also very important to remember. And also we must remember this is done in a longitudinal plane. I have mentioned longitudinal plane between the 2 ribs. So this is one rib here, shadow, and one rib here. So you can, if you see like here 4 B lines, it means these B lines are abnormal. There is some disease which is causing the enormous B lines being present in the particular patient. So the causes I have already mentioned, it could be the pulmonary edema, interstitial pneumonia, parenchymal lung disease, atelectasis, pulmonary contusion, pulmonary infarction, etc. So the questions we should ask ourselves is, what is the clinical scenario? We must always correlate with the findings of the clinical history and physical findings along with the findings that we have obtained during the ultrasound. So is it unilateral or bilateral? There are certain conditions which might happen unilaterally, certain conditions which we might visualize bilaterally. Is it homogeneous or patchy? The location, whether it is located in the apical part or the basal part. So we must always correlate with the scenario. Just take one scenario or the pulmonary contusion. The person has suffered from road traffic accident, and we find he was stabbed some injury to the right one side of the chest cavity only. So definitely he will have the unilateral finding. So this will be unilateral, focal, and there is the
fusion.
So
and so the scenario that you see, the place that you look.
So in this patient, we have seen the multiple B lines were present. So definitely it was
Fusion.
the condition
And
of
so-
the pulmonary contusion. Similarly, if you see the interstitial pneumonia, so we can see here is the pleural line. Like I can play the video for you, small video.
And given the fact that we know that people are either upright or laying flat on their back, right? And if you got, pneumonia, you feel really crummy, you're probably just laying around and
So in that part, for the
and-
interstitial pneumonia, also we can see the several B lines also. In atelectasis also, we can see several B lines present, more than 3 in number. So that would be the unilateral, bilateral, depending on the condition which has caused the
micrograms, but
B lines. Similar to the
Or they might
interstitial
have COVID.
pneumonia, the ARDS also. For ARDS, we must remember there should be generally present bilaterally. For the pulmonary edema also, it should be present bilaterally. And also in this picture, we can see several B lines here. So more than 3 in number, so definitely. And bilateral, so definitely we can conclude this diagnosis of the pulmonary edema or the ARDS. Similarly, the pulmonary fibrosis, similarly also. Now let's come to the pneumothorax. We should have 4 signs that we can achieve during the pneumothorax in the chest ultrasound. That is the absence of sliding sign that was mentioned in the video also. Absence of bilus, we will not see the bilus because the parietal and visceral pleura has been separated by the layer of the air. So the bilus will be absent. And absence of the lung pulse, what happens if, particularly in the left side of the thoracic cavity, the heartbeat will be transmitted. The transmitted pulsation can be seen in the ultrasound. So if there is the absence, that also gives a clue to us the patient might be having the pneumothorax. And presence of the lung point that was mentioned in the video also, that the sliding side is absent, the lungs point is present. It means at some point the pleura is moving, at the another point the pleura is not moving. That's the transition point. It means above that there is the pneumothorax. Below that there's the normal lung, non-collapsed lung. So that's also, this is a very good algorithm to make a diagnosis of lung sliding. If the lung sliding is present, you always exclude the diagnosis of the pneumothorax. If the lung sliding is absent, there might be pneumothorax or might be some other illness. So if the lung sliding is not present, and if the B lines, we look at the B lines, if they are also absent and the lung point is present, then by definitely you can say the patient is having the pneumothorax. So all the 4 signs that I have mentioned should be present to make a diagnosis or conclusion of the pneumothorax. Talking about the consolidation, several entity can cause the consolidation. Could be the pneumonia, pulmonary embolism, lung cancer or metastasis, the lateral excessive pulmonary contusion. So it was shown in the video also. So the consolidated part of the lung will be similar to the liver. So that is called hepatization. Or we can see that, for example, this is the diaphragm. Below the diaphragm is the liver. So the consistency of the liver, and above that is the lung. Let's suppose this is the normal lung, and this is the consolidated lung. So consolidated lung will appear just like the liver. So that's why it's called the tissue sign or hepatization. And above that, this margin demarcation in between the lung and the normal lung and the consolidated part will look like shred. So that's called the shred sign. So that all we can see in the pneumonia. To talk about the sliding sign, it can be present. It may be absent in certain situations because quite often the pneumonia may be associated with the pleural effusion. So at that point of time, we may have massive pleural effusion, we might not visualize the sliding sign. If there is the atelectasis massive, also you may not visualize the sliding sign. So it depends upon the condition to condition with which the pneumonia is associated. So here in one of the example, the patient has got the pneumonia. We can see the diaphragm here. This is the spleen because the patient has the pneumonia in the left side. So we consider the spleen also a sort of the hepatization. And here we see the normal lung. And here this part looks like the spleen. So here you can see again. So here the diaphragm, this is the consolidated lung, this is the normal lung, and here is the line. So this is the shred sign is present, this is the aerated normal lung, and this is the below is the diaphragm, below it could be the liver or the spleen. So these things we can visualize in the lung ultrasound very well. Here also the same picture, we can see is the diaphragm is very clearly seen. Here could be the kidney, here could be the liver, and this part is the consolidated lung. So this is totally different from the normal lung parenchyma. So we come to the diagnosis of the lung pneumonia. Here we can see very clearly the diaphragm, below is the liver, then the kidney, and the above part is this one, this part is the consolidated lung. So this is very important. Quite often we can miss the diagnosis of consolidation in the chest X-ray rather, but we will not miss the diagnosis of consolidation in the lung ultrasound. Regarding the pleural effusion, this was the most important thing that I wanted to highlight because we are very much concerned about the quality of the pleural effusion, now whether we are going to cure have some palliation for the patient from the point of view of the eradication of the pleural effusion. So if we compare the chest X-ray and ultrasound, till now we know that chest X-ray is the gold standard, if not CT scan. So if we take the chest X in upright position, there should be more than 200 of the fluid present so that you will see the blunting of the costophrenic angle. If the lateral decubitus film, as little as 50 ml can be detected. For the supine film, there should be more than accumulation of 500 ml in order to visualize some of the changes in the chest X-ray. Whereas for the ultrasound, even as little as 5 ml of the fluid can be detected by ultrasound. So you can just see, so definitely we can comparing these things, the ultrasound scores over the chest X-ray. So UST of the pleural effusion, I said the sensitivity is 97%. The diagnostic accuracy is 93% for the pleural effusion. In the pleural effusion, the sliding sign is typically present, except in certain situations where there is the massive effusion causing the atelectasis, then the sliding sign will be absent. The complicated effusions like chronic empyema, there may not be any movement of the fixed mediastinum because of the chronic empyema, hemothorax, the loculated effusions, or concurrent pneumothorax, pneumothorax, so at that time the sliding sign will be absent. So we, during the pleural effusion, we evaluate the patient for the echogenicity of the fluid. We evaluate for the septations, the pleural nodularity, the configuration and mobility of the diaphragm, and the quantity. These things are very important from the surgical point of view. So this is the anochic fluid. This is the diaphragm, this is the collapsed lung, and this is the fluid, whichever is present. This is the fluid. So we can see in this particular patient, this is anemic fluid, means serous fluid could be present there. So such patient will be very easily responding to the antibiotics of some sort of drainage, because it's very thin fluid, non-proteinous fluid or transudate fluid. At the same point, we can see the exudative fluid. You can see like sand-like appearance. In the thick fluid, the viscous fluid is present there. It could be pus, so it will be difficult to treat in this scenario rather than the previous one. So this echogenicity of the fluid can be said, this is the echogenic fluid here. The septations is the diaphragm, this is the liver, this is the lung. We can see the fluid here and the various septae. So this kind of pleural effusion are difficult to treat with the surgery or any other treatment. So therefore, at that time, there may be the role of the enzymatic therapy. So we can come to a conclusion what kind of treatment we should give to the particular patient. Pleural mets or cancer, the pleural nodules, any pleural is more than 5 mm, favor the malignancy. Pleural thickening more than 1 centimeter also favor the malignancy. Concurrently, if there are some hepatic deposits, that definitely will come, you will have the probability the patient has got the malignancy. And combination of all three, if there the sensitivity rises 79%, and look at the specificity, it's almost 100% specific if somebody has got the pleural nodules more than 5 mm, pleural thickening more than 1 centimeter, and at the same time the hepatic deposits are present, the definitely specificity is 100%. In this particular picture, this is the diaphragm, this is the liver, this is the effusion, this is the collapsed lung, right? This is the lung, collapsed lung. This is the fluid, and we can see here a nodule here, right? So this pleural deposit is suggestive for the malignancy. I mean, the pleural deposit may be lung cancer or some other cancer which has given the pleural metastasis. Very important to quantify what volume of the fluid is present in the lung cavity. This is very important from our point of view. So there are several formulas for the calculation. So we can calculate the fluid either in the supine position, we can calculate even in the erect or standing position, sitting position. So first let's look about the calculation of the supine position. So there is very important formula, that's the Balik formula. It's the supine position, probe orientation is the transverse, and posterior axial line used it is done in the end expiration. The formula is very simple, A into 20. Let's see the formula here, how it is done. We can see in the next picture, the patient is lying supine, a little bit leaning forwards, and the probe orientation is transverse, not the longitudinal, right? And with the posterior axial line is used, and we apply the formula. We can see here, this is the chest wall here, this is the lung, and this distance is the A. And if we multiply this distance A into 20, and this will be the approximate value of the fluid that is present in the chest cavity. So there's very simple formula, but supine position used. I think personally the supine position is not a very good examination property. So we should always use the erect position or standing position or sitting position. That will be a better estimation of the fluid value. There is another formula, the Ebenberger formula. This also have some formula like it's written here. The probe orientation is again transverse, patient is lying supine. I want to measure the chest wall from the lung, it is the A value, and then we can calculate according to the formula. The very important thing that I want to highlight is the calculation of the upright position or sitting position. The position, there is the two formula, one is the one formula. The patient is sitting, the probe is the curvilinear probe, posterior axial line is used, the longitudinal direction of the probe is used, not the transverse. And calculation is done at end expiration, not at the inspiration but the end expiration. The formula is H into 90. So how it is done we can see in the next film. The patient is sitting like here. This is the diaphragm, this is the liver, this is the lung. We measure this distance. Now we use the formula that was the Goik 1 formula that I showed in the beginning. This is the H into 90. H means that distance. This distance is H. So if we multiply by 90, that will give the approximate value of the volume of the fluid that is present. The another formula is Goik 2, its second turn in the sitting position. Again, the convex probe is used, and the formula that we use is H plus T into 70. So we can see how it is used. This is 1, H1 is this distance, and D1 is this distance. From the lung, this is the lung. From this the lung to the diaphragm level, center of the diaphragm, hemidiaphragm. So we can use that formula, Goik 2 formula. There are other methods also, but I personally feel that for this simplicity, either we can use the Goik 2 formula or the Goik 1 formula. That can be done very easily in our department also. We can approximately identify what value, what is the amount of the fluid, whether he requires a physicosynthesis or he requires chest tube drainage. If the massive effusion is there, you can calculate that one. So this is the same picture. There was a very good literature review regarding the calculation of pleural fluid and estimation using the ultrasonography that was present in, that was published in the Respiratory Science in the 2022. It's very good review. You can go to the literature and look for that. So in the pleural effusion, we can have the spine sign also. Besides all those quiet sign that I mentioned earlier, you can have the spine sign also. Generally, in normal person, if there is no effusion here, the vertebra is seen only below the liver, like the liver or spleen, you can see the vertebra. But if there is no pleural effusion, you cannot see the vertebra here. This is the normal lung. This is the normal lung. We don't see the vertebra like here, side wing of the vertebra is shown below the diaphragm, we don't see here. If there is the effusion, in this context there is the effusion, we can see the shadow of the vertebra here also. Here also, downside also, here also. It means there is the spine sign is present or the effusion is present there. Similarly, in the normal lung, if we can see the seesaw sign, as shown in the first picture, in the context of the pleural effusion, since the lung is collapsed, you will see the sinusoid sign. So that is present in the, not in the normal lung, but in the pleural effusion, you can visualize the sinusoid sign. So this is the white sign I showed before. This is the reef shadow here. This is the reef shadow is the lung, and this is the quadrangular pleural effusion that present, that is called the quad sign. That is also peculiar for the pleural effusion. So there are several things. The similar picture has been shown here. There is the grading by the ultrasound. The grade 1 is the minimum, grade 2 is the small, grade 3 is small to medium, grade 4 is medium according to how many intercostal spaces are involved. So we can roughly calculate to which grade the patient belongs to. So there are the key points out of this that I mentioned here. The sliding sign is present in the normal lung. The sliding sign is absent in the context of pneumothorax, complete atelectasis, the pleural adhesion, main bronchial obstruction leading to the atelectasis, pneumonectomy patient has undergone, severe ARDS, pulmonary fibrosis or fibrothorax. So these are the things where the sliding sign will be absent. So let's discuss some of the quizzes out of these lectures. So this is the first thing. Well, answer so Sandeep, can you see what do you find during the ultrasonographical image in this particular patient? What is this?
There is a diaphragm, sir.
Diaphragm. What is this?
That is the lungs.
Collapsed lung. And this V, this is also called the V sign, this is the fluid, right? So indeed this patient has got the pleural effusion, right? So if the quantity of the pleural effusion rises, you see this is the diaphragm. Diaphragm gets more and more depressed. Here it's more depressed. Here it was more like this one. Now it's getting depressed. Sometimes massive effusion, it will go to the reverse direction also. So the diagnosis in this particular patient, the stages of the empyema, exudative stage, fibronopurulent, sorry, you have to question on that. Well, I have to diagnosis. So this is the case of empyema basically. Septations are there, and this is the stages of the empyema. Patient presented first in the exudative stage, this is the A picture. Then went to the fibronopurulent stage, second of the empyema. And third is the organizing stage, the dense consolidation is present. So this is the stages of the empyema that we can even follow up the patient with the sonology or ultrasound. Right? This picture, Asis, can you comment on that? What do you think? What's this? Just to guide you, we can see something is here, right? You can see something distinct. It's 1 point, 2 is there.
This looks like there is some thick material floating down with thin material in above. So
Very good. So the diagnosis is with the hemothorax. Like, so this is like the hematocrit sign. So if the blood clot in the beginning, if somebody has road traffic accident, you will find this something's precipitation is down. Right? So there's the same thing I said. Describe the effect of the pleural effusion on diaphragm. What do you think? Describe the effect of the pleural effusion on the diaphragm. This is the diaphragm. This is the lung. This is the effusion. How would you describe the effect of the pleural effusion?
The increase in the amount of pleural effusion pushes the diaphragm caudally, resulting in flattening initially and then later concave.
Very good, very good. So this is the correct answer. This is because as the effusion increases, there will be the flattening of the diaphragm, and therefore the dysfunction of diaphragm may cause to the respiratory distress. In this particular picture, Sandeep. So, there you go. Answer.
There are B lines.
So there are several B lines present, right? So indeed this is the interstitial, thick interstitial, right? The CT scan also, in the chest X-ray also, we can see it's going, bronchovascular margins are prominent, and it's bilateral located. In the CT scan you see the similar things. In the ultrasound you see particularly the B lines, right? So this is typical for the pulmonary edema, right? Now 19 years male patient, habituated to vaping, presented to ER with cough, shortness, suppression, progressive shortness, SpO2 is 70% of the room air. This is the CT picture, X-ray and CT picture and the ultrasound. Can you describe the CT and ultrasound sonography findings?
So in first chest X-ray, there is a heterogeneous opacities in bilateral lung field, and in CT scan we can see the same opacities in bilateral lung field with fibrosis of the parenchyma, and then in USC there are multiple B lines projecting.
That's
down.
correct. So we should come to the conclusion there is some sort of the interstitial edema is there, right? So interstitium involved here. So what causes? We have the history of vaping. He was habituated to the vaping. So this is the entity is called the E-valley, e-cigarette associated, vaping associated lung injury. So this was typical condition. This is quite common in the beginning because this is the nicotine contains something, e-cigarette contains some sort of nicotine, which causes the injury to the lung. I don't remember exactly what's the...
Glycerin.
Something like glycerin or something, that's true. Some material which causes the lung injury. The next picture. Can you describe the CT finding, X-ray finding and the sonological finding, Mahesh?
In the X-ray,
It's not very clearly seen, but in the CT scan it's very clearly seen.
the X-ray shows the right side of the lung, with the small area of low bronchovascular marking in the uppermost part of the pleural cavity, and as shown by the arrow as well. And that's in the CT scan also, the anteriormost part of the pleural cavity, anterior to the lung, is just empty, and which signifies there is air in the pulmonary pleural space. And
Pneumothorax, right?
Pneumothorax.
This one, this one.
And in the M mode, we can see there is no normal seesaw sign that is seen in the
That's
M
true.
mode.
So what sign is it called? The barcode sign
Barcode
or a
sign.
stratosphere sign, right? Because there is no sea and sand. So therefore it's very typical example how you can visualize the pneumothorax in the ultrasound. Another example, 10 years male presented with 1 week history of cough, fever, chest pain and shortness of breath. We can see this picture. How do you describe this picture, Asis?
So in the chest X-ray there is complete opacification of the right chest field. The CT scan also corroborates the findings with presence of pleural effusion and atelectatic lung. In the cross-sectional image, we can see.
No, this is the sonology, ultrasonography. This one, the ultrasonography image.
Ultrasonography, we can see most likely these are multiple loculations. Multiple loculations.
This is the empyema, right? So it was the pneumonia in the beginning and led to the empyema in the patient. So there should be there were certain example, illustrative examples. So now come to the future perspective. So I think personally believe that POCUS will replace the stethoscope for a clinician. I think it has replaced the stethoscope for the clinician at the bedside. Right now, I'm quite fond of Dr. Sagar. Right? So he just depends upon the seat. This is very good. If you are quite confident, you can depend on the chest X. So I also do not personally listen quite a lot of time with the stethoscope and the lung. You can better visualize the chest X-ray or CT scan. Similarly, I think right now also it has replaced for clinician the stethoscope. For low-income countries, it would prove the best diagnostic modality. In near future, it may replace chest X-ray in the post-operative patients also. That is my dream. Let's work together and let's replace the chest X-ray in post-operative patient. Don't do the chest X-ray, do the ultrasound at the bedside in the ICU or post-operative ward. And right now there is the era, the interpretation is done by AI and there will be less chance of the error. So thank you very much, and that's what I wanted to tell you. Any comments, any question? You heard straight sign man, consolidation man, pneumonia man. When you visualize this, for example, is the diaphragm. In between there is the consolidated area. That looks like the liver with spleen hepatization. And the demarcation between the consolidated part and the normal lung will look like zigzag on the straight side. So that is the straight side, which is typical for the consolidation. When you will visualize the tissue side of hepatization and the demarcation line between the normal lung and the consolidated lung.
So there was like a plankton sign. Empyema, plankton sign.
Maybe I may not be aware of many signs because we're surgeons, but these things I think maybe that's you can explain about if there's some other signs that have been described.
I was asking about.
No, I don't know. I myself I don't know what's that plantar sign. There could be some sign also.
It looks like an algae floating in the sea, sir, in Paimama.
Maybe I'm not aware of that. Maybe there's
Or
some
it's very
maybe there's different way of
floating,
describing the
floating
same
and
thing. Okay, योगेशले केही एड गर्छ किनभने द्याट्स भेरी इम्पोर्टेन्ट थिङ फर यु अल्सो होइन केही एडिसन हामीले स्टार्ट गर्न खोजेको छौँ वान स्टार्ट होइन चेस्ट अल्ट्रासाउन्ड हामीले सुरु गर्न मेरो ड्रिमै यो हो कि भेजिटेटर कसैले लियोस् ताकि चाहिँ
यो चाहिँ पहिले नै ट्राई गरेको सुरुमा आउँदाखेरि मैले पनि धेरै नै गरेँ तर के हुँदैछ नि एक्लै गरेर नहुँदैन अनि जस्तो इमर्जेन्सीमा नि मैले अल्ट्रासाउन्ड लिएर गरेँ एकचोटि गरेँ तर त्यो बिस्तारै प्र्याक्टिस गर्दै गएपछि चाहिँ हुन्छ प्रेसिडेन्टहरू हुनुहुन्छ बेड साइडमा हामीसँग अल्ट्रासाउन्ड छ माथि छ त्यो चाहिँ रेगुलर चाहिँ जस्तो 3 राउन्डमा नै गरेर हेर्नुपर्छ जस्तो लाग्छ एटलिस्ट यो डिपार्टमेन्टहरूले चाहिँ आइसियुमा र यहाँ चाहिँ प्रोटोकलै डेभलप गरेको मैले पनि गर्नु खोजिरहेको
मलाई लाग्छ तपाईँहरूले पनि अब हामी पनि त यसमा चाहिँ के छ हामीले अल्ट्रासाउन्ड सुरुमा हाम्रो कहाँबाट आएको कन्सेप्ट अल्ट्रासाउन्ड डेभलप गर्यो कहाँबाट